Welcome back to the Sports Medicine Project, episode 120. With me, you're stuck with me, Blake Withers, and I'm solo today. I'm on my own because nobody wants to talk with me around foot orthoses. Now, I'm only kidding. Plenty of people want it, and we're going to have some really fun and hopefully good discussions in the next couple of months around this. But I wanted to do just a short episode on trying to help other people understand foot orthoses. And I'm going to give you an example. Because you're a podiatrist, you've got a pretty good understanding because you're utilizing them. You would have learned at university level, and you've probably done some courses or some further education on that. But for other health professionals listening to this, I want to be able to help you understand how we as a profession think of them because we have so many similarities between, whether it be exercise or medications or injections or surgery. So custom foot orthoses versus non-custom, what are the differences? When are they more indicated? How do we make that clinical decision? All those types of things I want to be able to answer because for a framework to think around, if a patient comes to see me, as an initial appointment and walk in the door, they sit down, I'm going to say, listen, I've seen this person, I've had Achilles tendinopathy, been diagnosed, and exercise didn't work. It didn't work for me. It isn't right, of course, for me to say, okay, then, well, let's rule out exercise. It's obviously not going to work for you. My next question after that is always going to be, okay, well, let's go through and just see if it was tailored for you. Did we get the intensity right? Did we get the dosage right? Did we avoid compression early on? Did we go into compression too early and we didn't have that maybe with some heel lifts and some shoes so it felt a little bit better? Did you do it more frequent enough? Did they test you in the gym? Did they watch you do it? All these types of things that we need to go through. And I know that I'm able to evaluate that and kind of make the decision and then show them and say, hey, yeah, you said you've done exercise, but you've done stretching or you've done some heavy deficit calf raise into a lot of ankle dorsiflexion, and that just stirs up your tendon. And that means it's really hard for you to keep doing the exercise and you haven't got the consistency. You've really struggled to then build the capacity and the strength, and maybe you've done a little bit too much of the passive and like the active or vice versa. And I'm able to evaluate and communicate that. And I think with other health professionals, my experience online has been that potentially other health professions don't have the tools or no one's really explained like, yeah, this is how we think of foot orthoses and this is how I explain it with my patients. So that's what we're going to try and cover today. So when we think around what are the principles and what are the kind of guiding biomechanics, we think of orthoses just like any other load modifier. Just like when you tell someone to do a little bit less, so there's not enough stress, on that tissue. Let's say it's the tendon. I want you to do a little bit less faster running. So there's not much tensile stress, and I want you to avoid dorsiflexion. So there's not enough compressive on the Achilles, and I want you to try and avoid how many steps you take. So when your heel hits the ground, it's not getting as strong the tissue can recover. And your knees sore in the gym, I want you to reduce your squats or your lunges or how many times your knee flexes because the patellofemoral joint is going to be able to settle down a little bit quicker. So we're just utilizing them to unload a tissue that is sore because we are thinking that that should be able to help the tissue to recover better, which is an awesome bonus and get this person back to what they want to be able to do. And secondly, it can help with their pain. We're not trying to correct or change, the foot because it's wrong and the foot's caused all these issues. The idea of trying to have the foot function in this perfect subtalar joint neutral or this perfect position. Although people can still get relief if I was to say to someone, I'm going to give you this orthotic and stop your pronated foot and it's going to be a neutral foot and you have associated tibialis posterior pain, guess what? That's going to help that person, but it's probably not helping him in the way in which I think. And we see this everywhere else in posture. You sit forward for 50 minutes at a time, your neck on a weird angle, and someone says, hey, fix your posture. It needs to be perfect. And you move and change it and it feels better. It's not because the posture was wrong. You just change the position. You're probably putting some stress somewhere else. As the saying goes, your best posture is your next posture. So I'm not thinking around my orthotic design to do this. I'm thinking I want to take some stress off a painful tissue. And then when we think of that, we can start to then move a little bit away from some of the older theories, although we're still using a lot of the material science and understanding how the foot functions. Because although I'm saying I'm not trying to correct the foot from flat to neutral or, from really lateral incavus to neutral, I still need to have a pretty basic understanding of foot biomechanics and how that functions. Like, let's use the subtalar joint as an example. If I just think, yeah, the subtalar joint just works in one plane, it's the sagittal plane. We know it works in it's triplanar, it works in the transverse and the frontal. and in the sagittal plane, but mainly in the frontal plane, which is going to be inversion and eversion. And if I'm thinking around how I'm going to apply force to that foot, if we've used the subtalar joint axis, and I don't want to get too much into that, but if you imagine an imaginary line going in through the foot, that's on a bit of an angle, and let's say it's going from the lateral to the medial. Let's just say it's going straight through the foot. That'll be a little bit easier to think about. It doesn't go just straight through the middle, but I want you to imagine that, and this gives you an idea of how we think with kind of biomechanics. So the axis is going straight through the middle of the foot. If I apply some force with my fingers on the inside, if I'm just using the subtalar joint, I'm going to apply some force. That force is going to be, I'm going to apply a pronatory force that is going to supinate the foot, or it's going to evert the foot. And because of that line going through there, imagining the foot's going to rotate around that. And same will be said if I apply force on the outside. So I still need to have an understanding of that, and it's really beneficial when it comes to then thinking around, well, do we use foot orthoses for everyone with lower limb pain? And of course that we don't. Could we think of the Achilles tendon? Well, if I'm going to use my foot orthotic to have a lot of influence over the subtalar joint and that inversion and eversion, how much influence is that going to have on reducing the tensile force for a mid-portion Achilles tendinopathy? It's going to have some, but it's not going to have a lot. And that's because of where the Achilles tendon inserts onto the base of the calcaneus. Now, if I talk about the tibialis posterior, that's a whole lot different. If I think of where that inserts in the main insertion, navicular tuberosity, as the cuneiforms, if it's on the inside, if I'm able to apply some force around the subtalar joint and reduce how much the pronatory excursion, basically how flat the foot gets, I can reduce that tensile strain and some of that compressive strain into the tib post. And because the tib post goes past the ankle and past the subtalar joint, and it has a big role to play when it comes to the subtalar joint, I'm going to be able to influence it more. Now, if I think, well, I'm thinking again with the subtalar joint, the plantar plate, or let's say the second or third metatarsal phalangeal joint, if I'm able to influence the subtalar joint a lot with the foot orthotic, well, how much is that going to influence the plantar plate as we get to push off? Probably not a whole lot. It will a little bit, but not a whole lot. So that's where this clinical reasoning and understanding will come into our foot orthoses prescription, and thinking as well. If someone comes to see me and they say, I tried foot orthotics for my Achilles tendon, great, we'll have a bit of a look. And the main thing I'm worried about is, like, do they have a heel lift? And I'm probably just going to give them an 8mm heel raise and a high pitch shoe. Whereas if they come in and say, I had a foot orthotic for my tibialis posterior pain, I want to be able to pull out that device and evaluate it properly, because it can have a greater influence. So I'm thinking, well, is the shell shape adequate? Did it have a medial flare? Did the heel cup at the back come up and up? Was the material firm enough? So all these questions that come into it. So for other health professionals, I'm going to try and give you a couple of bits of information to at least be able to evaluate if it's adequate, because they're very clearly a good quality evidence-based treatment, and they can really help people be able to manage their symptoms today. I mean, if you're looking at someone that's managing below knee pain and they're spending 8 hours on their feet, or they're running 50, 60, 70 kilometers a week, and let's just call it loading cycles, someone with compressive heel pain, if they're taking, let's say, 200,000 steps a week, every time the heel hits the ground, we count that as a loading cycle, and that's stress through the tissue. And at the moment, we can at least assume if they're coming in for us, the stress is too high for the tissue to recover. So all we're trying to do is bring down that stress so it can recover. And we do it in lots of ways. We use cushioned shoes, we use taping, and we might use a cushioned unisole or a foot orthotic as well. So hopefully that makes a bit more sense. We're using them to modify load, modify stress, let that tissue recover, and then we can speak around, well, does that tissue still need the stress away from it? And that's the question we're always asking and talking around with our patients. Do you need this for the long term or the short to the medium term? And we have that open communication with the patient. I do get annoyed a bit online when I hear other practitioners saying that they've been heard from their patients that, yeah, the podiatrist said I'm in this for life, and I'm not aware for the people that I speak to that anyone is actually saying that. And to provide some support for maybe the people who are, and to have some critique of others, when we are speaking around them, it's always a nuanced conversation. We know very clearly the prognosis of some of these conditions. The prognosis of plantar heel pain is a whole lot better than the prognosis of midfoot osteoarthritis or adult acquired flat foot or CMT, or someone with low tone hypermobility and a connective tissue disorder. That they're very, very different. And we have some clear research on this. If someone comes to see me and they have heel pain that's been going on for a couple of weeks versus a disabling adult acquired flat foot, structurally changed foot, it's a whole lot different around, listen, this is probably going to recover within the heel pain and we can manage the symptoms, and get you back to a full recovery. And on the other side, we're doing the same thing, but we need to acknowledge the reality. There's some changes in the physiology of the tissue. Your plantar fascia has a different adaptation cycle to the joints that are arthritic in the midfoot. And you look at knee osteoarthritis, if anyone sees anyone with knee OA, I'm sure you're not saying to them, yeah, we'll get this better really quickly. It'll go okay. Of course, we'll try to do that. But there's some changes in the physiology. The cartilage is different. We don't have replacements for cartilage at the moment. And that's why people are getting knee replacements. We have some other adjuncts, which I'm not going to speak about, nor am I qualified to speak about our injectables and things like that. But we can talk around, managing comorbidities and weight and that kind of thing. And we're still doing all that in the foot and the ankle. But I want you to kind of ask the question and certainly ask the patient, do you feel better using these foot orthoses? Like, do you feel as though your quality of life is better? Is your pain less? Do you feel like you can get around more on your feet? And we can certainly try and utilize them less. We're acknowledging what's happening with the foot. You have an understanding of what I'm saying. And let's try and utilize them less and see how we go. We can try and work on some foot capacity and strength, building up the calf, the foot intrinsic, getting some more time on feet. But if we're trying to do this and you're really struggling and you're having flare-ups and you're getting quite down about it, we might have to utilize these a little bit more, and it might be for the foreseeable future. And here is why I'm saying that. And that's different to what I would say with other conditions. So I would like people to, of course, be aware that these cases are happening, and we are working with these cases. And this is what I'm saying with my patients. Again, we're trying and hoping for the best, but acknowledging the realities. We can't just say, great, you're not going to be in this for life. All foot orthoses are short term. But to kind of counteract that as well, there are cases where people probably are in foot orthotics and they don't need to be. And we have that conversation around trying to test your resilience and spending a little bit more time out of them and getting the foot moving a little bit more and the tissue a little bit stronger and more capable. That takes a really, really long time for people to do. And of course, we can do that. But people have a lot of things on their plate, and they can put this foot orthotic in their shoe and they feel a little bit more comfortable. I can explain the risks and associated potential consequences, which are quite minimal. The evidence is very mixed. Thinking of what you tell me, I'm aware of the research on foot intrinsic changes. Some get stronger, some get weaker, and everyone in the middle. So we don't have any consensus on that. But again, it's about the person. If my mum had some heel pain and she felt better in her cushion or intersoles and she can do more walking and her quality of life is better and she's more active, like, that's meaningful for that person. And I would challenge clinicians that are saying, like, come out of these too quickly, to ask your patients and have that open dialogue. So there's merit to both sides. I believe that more people can spend less time in them. And I also believe that some people, are going to have a better quality of life. But again, it's with the person in front of them. I can never give, general overarching advice, because every person I work with and I sit down with, I'm explaining their situation. We're talking through their situation. And that's a part of being a good clinician. So when you're thinking as another health professional and like evaluating foot orthoses, it's difficult because you don't learn around the features, and this shell's a little bit stiffer, this one's a little bit more flexible. When does it matter? This person's got a sesamoid injury, and am I focusing on the rear foot? Is the arch matter, or do they have something particular and different? So I would encourage you to look through some of the research. I mean, on my socials at Blake.Running.SportsPodiatrist, I'm trying to put this up so people can evaluate. But the way to kind of think of it is, with your device, you'll have the midfoot, you'll have the rear foot, the midfoot, and the forefoot, and you want to have some features within those areas that are specific to the tissue. Because when I'm thinking around my design, again, I'm not thinking making the foot neutral. I'm thinking, what are the affected tissue, or what is the affected tissue? What are the bigger loads that tissue is subject to, and how can I reduce those? So when I make that clinical kind of decision and move through those steps, I can then start to use the next step, which is material selection. And this is where the difference between custom and non-custom come out. So if I'm imagining I have someone come in and they have a pretty neutral foot type, and I'm going to explain why I'm saying why their foot type matters. They come in with a pretty neutral foot type. They weigh about 70 kilos, and it's been going on for 3 months. And let's just assume it's those things happening. Now, I know how much I'm going to be able to influence and load through that peroneal tendon. We know the peroneal, what we want to do to unload that is I actually want the foot to pronate so I can unload and reduce that stress, that tensile and compressive stress in through that tendon. So it's really important I have the right diagnosis. That's very different. If someone's got a fibular stress fracture, I'm probably not going to be using foot orthoses in those cases. So just want to be clear that we want to get the right diagnosis. So I know the bigger loads because it's a tendon. That's going to be different to a joint, which is a little bit more compression. So I'm thinking, all right, how can I reduce those loads? Well, if I just very simply use my biomechanical brain, if I just put lots of material on the outside or on the outside of the axis of the subtalar joint and some other joints as well, I'm going to pronate the foot and I'm probably going to take some stress off that tendon. Now, I know it sounds really simple, but I'm saying it's simple so we can then start to add layers to that. Now, of course, comfort's a big factor. I can't just stick some rocks in there, although biomechanically the rocks should probably work. They probably wouldn't put any pressure on there. But I need to make it comfortable. I need to make it fit into the shoe. And let's say the same case comes in and they have a really cavous foot. They have Charcot-Marie-Tooth disease. They've got low tone. They've got no real stability around their ankle. It's a connective tissue disorder amongst some other things as well. And every time they walk, they really supinate their foot. They have a really cavous, and they're just overloading and overstressing. They've gone through all the rehab, and they just can't get it under control to even begin and start the rehab because it's so sore. Now, in that case, I know to pronate the foot, I'm going to need material that is firm enough and stiff enough to be able to make the foot move in the direction. So I know I need that as one factor. And then also, I'm going to need the actual design of the orthotic to do something different. So the standard non-custom soles will come as standard nature. They're made to the average. Whereas with the custom, I can make the outside border really ramp up and call that a lateral flare. That comes all the way up the outside. And that's going to provide some force to the outside of the foot. And that's going to move some of the stress away from that tendon into the inside. We're going to load, of course, the tib post, the medial structures a bit more. But that's good because I can unload the tissue that is sore. And we can also do some other things as well. If we know the peroneal tendon is a plantar flexor, well, then great. How do I unload the plantar flexor? I'll probably put a little heel raise in through there. And you can start to see how we build the design. Now, I think, well, where does the peroneus brevis run? Well, peroneus brevis on the base of the fifth, peroneus longus comes on base of the first. And I think, well, if the whole foot's supinating, rear foot, the midfoot, they're probably going to be pushing off the outside of their foot. So what I might do is I might put some material under the outside of their forefoot. And that's going to encourage, because when they push there, like, oh crap, the material's there, I have to move my weight over to the big toe. But then on that one as well, what material should I use? If I use a soft cushion, it's probably not going to work too well. If I use a hard plastic, that's probably not going to be tolerated as well. So I might use a medium density EVA, which is a good bridge between firm and soft. Maybe if it's a bigger person, I might use a firmer, or they've worn something before that's had some material there. I might go firmer as well. So I want you to hopefully understand a little bit how we think around, design and what we might do in considerations, because I always explain it very simply so we can start to build from that. But there's some complexity that goes into it. If that person comes to see the physio down the road and says, listen, I got this orthotic from Blake, custom orthotic, he explained why I need it. I need a more force application. I do have somewhat of a deformity within my foot. I've got low tone. I need the material to be stable. That's why I got the custom. He goes, oh, great. Yeah, that makes plenty of sense to me. I listened to that podcast that Blake did, the Sports Medicine Project. He's a lovely guy. Kidding, hope they say that. So they go, oh, but it's not comfortable. I don't like it. I don't think foot orthotics are working for me. So what I would hope is that practitioner will then say, no, that's okay. That happens all the time. I give my patients exercise programs, and sometimes they flare up and they don't like it. But I know it's not the exercise itself. It's probably the dosage. So then I would hope that practitioner pulls out that device and goes, okay, you've got a firm material which you need to generate more force. You've got a lateral flare that comes up on the outside. That's good. That's going to provide some stability, just like a brace would. Are you getting where does it feel uncomfortable? And they kind of point to the forefoot. And let's say the patient goes, oh, the material doesn't feel very comfortable. It feels too thick. It doesn't fit into my shoe. Hopefully the practitioner or the physio goes, oh yeah, that's fine. They can adjust that. That will take them like a couple of minutes. They can adjust the dosage just like I adjust my calf raise prescription. I might have given someone 20 and it made them sore, so I'm going to give them 10. Or I told them to run 5K and they got sore, but they don't have pain at 3K, so I might say, let's run 2 kilometers. So as a recommendation, it's like, yeah, great, go back and see them, call out the clinic and just say, hey, I've had a problem with my orthotic. Can you come back in and help me out? And they'll be able to come back in and I can adjust that. And truth, I can adjust that in 5 minutes. All I have to do is grind down the material. I have the tools within my clinic. And it might be me taking 1 mil of that out, put it back in. How does it feel? Yeah, it feels good. My shoe fits good, but I still have some of that stability. Or they put it back in and go, it's way too full. I take it all off and we put it back in. That's okay. I'm just adjusting and finding that dosage. And then you can start to see how we utilize them just like any other treatment. But the idea of the custom versus non-custom, I can still have some force application or that material do something to the foot with a simple off-the-shelf device that I've built into support, and I've customized it to their presentation. We kind of call them a medical grade customizable foot orthoses. I can still do that, but if I'm thinking durability and long term, and then being able to provide more support, I can theorize in my mind it is probably going to be superior. And if, as an example, if you just pick up a bit of material in front of you, pick up something that's soft and something that's firm, the firmer stuff holds its shape when you try to apply pressure, and it's just a classic deformation, like for bones. I mean, if you've got a stick and then you've got a bit of, we'll call it, say, like cushion from a shoe, and you try and bend the stick, it takes more force to bend the stick compared to the cushion. So the same thing when someone's applying a force to that with their foot, it's going to take more force. So we're going to be able to oppose some of that force and hopefully unload the tissue. And it's all coming back to unloading the tissue. If someone with that supinated foot is really now pronating, but they're feeling really good, their quality of life is better, and they're feeling comfortable, and everything else is going okay, well, awesome. That's the goal. And again, we can adjust that and change that. And sometimes, I'm not saying overcorrect, because that's not a good term, because we're not correcting anything. If they say, "Oh, I feel like I'm putting too much weight onto the inside," that's fine. That's okay. I just took my best educated guess. Let me just adjust the outside a bit so we can have you feel a bit more even. I don't care about your subtalar joint neutral position. I care about what you're saying to me, and then I can hopefully start to have that person understand what I'm doing. So as a general framework for people to think about, when we might consider a custom over a prefabricated, a medical grade customizable foot orthoses, what I'm kind of thinking is what I mentioned before. We might be talking around, deformity. So if someone's got an adult acquired flat foot and their foot has structurally changed, the ligaments, the soft tissue, their tendon's got some insufficiency, and it's just not doing the work that it needs to, I might think I'm going to need something that's got more stiffness within that material. Durability is a big one. Work with people in the army. Their devices are going to be subject to a whole lot of different rain and mud and everything kind of else. So we need to make sure we're getting that right. If I'm managing someone with a stress fracture or MTSS in the tibia, I'm trying to reduce the plantar flexor load, my heel lift, and whatever I'm doing to the device, which would usually be something on the medial side because the plantar flexors are on the inside and they do a little bit more than the ones on the outside. I want that to be able to last. So force application is a big one. If I'm trying to have more force to an area for, say, a bigger person, maybe a foot that's a bit more out of the average, or quite a flatter foot, or a foot that's quite cavous. You see, I'm using these words, but I'm hoping you're understanding, I say, a flatter foot posture with an associated pathology. If someone comes in asymptomatic with a flat foot, I'm like, cool, your foot's adapted. This foot's awesome. I love this foot. You love this foot. We love this foot. But if there's an association where their tibialis posterior, maybe their big toe, their flexor hallucis longus, their sesamoid, their deltoid, their plantar fascia, well, then I can use my biomechanical mind to say, well, we should be able to know that these tissues are under stress. I'm going to use this device to unload them. And when it's better, we probably won't need them at all. And we'll see how we will cross that bridge when we get to a majority of people. I don't need it, just like Panadol for a headache. So the prognosis of conditions as well. I was teaching a course on the weekend, and I used an example of someone with a chronic Freiberg's that's got a degenerative second MP, and they're really MBJ joint, and they're really active. So we did a stiff extension underneath there out of a relatively flexible but firm plastic. And what that would do is that would then reduce how much it bends and take away some of that pressure. And also patient preference. Some patients just want to have a custom device, and it can be from numerous factors, from they think custom is always better when they do that, or something around their health fund maybe covers more, whatever it may be. There's some utilization there. So if we're starting to think around that, then we can make these better informed decisions. And then also speak with our patients where they say they come in and they have some heel pain, and they ask you as a physio and say, or a chiro or a doctor or a surgeon, say, do you reckon I need custom orthotics? My heel is really sore on a touchdown. Like, oh, well, yeah, it's a good question. I mean, how much? Have a look at the foot. Well, it's a pretty average looking foot, and it's really sore when you come down. It's more compressive. You probably just need something that's more cushioned. And we'll try some tape and some shoes that are nice and cushioned. And from an inner sole, they can probably use a medical grade foot orthosis and make it quite cushioned, or they may use a custom and use a particular material that is quite cushioned. And that's a discussion for the podiatrist and the other health, podiatrist and the patient, where if someone comes in with maybe some medial, let's say some typical arch pain, insertional tibialis posterior pain pretty average foot, hasn't been going on for a while, and they're managing pretty well, you could certainly have a good faith debate that they may just need something simple and we just beef up the arch a little bit. Whereas if someone with a dull decline flat foot comes in, well then they will need something that's more accommodating to the foot, that's wide in the shell and comes up around and hugs the foot and offers that support. So you can see how these things start to change. And I would encourage, you as a practitioner, reaching out to your local pod because, foot orthoses can have a really, really good outcome and it can really help people manage and certainly help the things that you're doing in regards to exercise. If someone's tendon or structure is sore at the end of the day, when you're trying to give them some rehab, I mean, this can really reduce maybe how sore it's getting and start to do that rehab process. So you can see around the biomechanics and the material selection, there's some complexity to it, but we're trying to figure out I'm trying to figure out the best way to help other professions understand, what we're doing and how we're thinking about it. Because my experience has been at biomechanics in this way, it's been a little bit played by like, no, this is a secret. Don't you dare even think or talk about custom foot ortho. You don't know what you're talking about. And for me, that's just never gone well. I want to show other professions what I'm doing and why, so we can work more collaboratively and they can better understand what I'm doing. And then when referrals are better indicated, so we can work for our patients and get those outcomes. And then you feel more confident evaluating when someone says, I tried for orthotics, they didn't work. Great. Well, let's have a look at them and evaluate them and see, did they give you some relief? Do they have the features, on the inside or the outside? Do they have maybe the arches ramped up, the heels a little bit deeper? And you can, as any practitioner, you can use, general common sense. Like if I've got forefoot pain and there's no pad, behind where the sore spot is. Oh, well, that's okay. Maybe there's some modifications that we could make. Go back and see the podiatrist and they can work. And maybe I'll send them a letter and say, hey, patient, so they were a bit concerned they didn't know what to do. And I was just like, at least a review. And then, you can better communicate. Or maybe it's really good. It's like, yeah, this is okay. There's nothing more that we can change or do, but it's still worth a review and just communicating. I mean, practitioners and clinicians, in my experience, are really nice and, calling up from the sense of like, hey, I just saw one of your patients. I just want to learn more about them. I've told them to come back for a review. This is kind of how I communicated it. And, patients feel like you're working together and you can hopefully get better outcomes. So hopefully that gives you a bit of an understanding of why. And you think, well, is anyone with foot pain who needs less stress through a tissue need foot orthoses? Of course not. The answer, there's lots of cases where, we don't need them. And I'll leave you with this analogy to think of. Majority of people, we think of foot orthoses just like Panadol for a headache. But for some people, it's a bit like type 2 diabetes, where there's probably that there are some things that you can do to essentially reverse some of that disease and maybe bring your BGLs and your HbA1c to a little bit more consistency, and maybe the medication dosage comes down and there's some lifestyle factors like, weight control and exercise and calories and all that type of thing. Now, I know, and listen, that's difficult. Having someone have a sustainable weight and meeting their physical activity guidelines is hard, and there's a pandemic of that at the moment. There's billions of dollars put towards trying to understand how we can do that. So I don't want people to think, or patients even to think, they're stuck in these forever, because you're certainly not. There's plenty of things you can do. You might have to commit to rehab for 6 months and do it every second day and really do it appropriately and consistently. We might be able to see some change. I can't guarantee that, but we can certainly try. And that might be like with this foot orthotic. You do function a lot better and all your metrics are better when you're in it and you want to come out of it. It's going to be difficult. And if you're a practitioner saying, yeah, everyone should come out of them, I would challenge you to go ahead and one, teach me and teach other people like how you're getting those results every time. I just don't know if that's happening. I mean, how you're managing a chronic midfoot OA who's had multiple surgeries and is overweight and they feel better in their foot orthoses, how you're getting around that, I would love to know. And then for some people, it's like type 1, diabetes, where that's something that's, genetically within them, of course, and the changes, it's not something that you can easily reverse. And that's why, it's such a disabling condition for people where, you need to have insulin, and that's something that you need on a physiological basis. It's very different. And that might be someone with a connective tissue disorder, maybe rheumatoid arthritis, maybe CMT, maybe they have cerebral palsy and they have a foot drop and they need to use a brace to hold their foot up. So, to the other people, and this is I work with a smaller population that have that, and they function so much better without that, and they can't change but what's happening there. So for them, telling them, hey, you need to get out of there as soon as you can, it's so detrimental to your health. That's not the case either. So there's these kind of categories that we try to work with. I just explain that with patients as well, and it seems to have made it a little bit easier to understand. And I hope it's made it a bit easier for the health professionals listening to this to understand as well. And you feel a little bit more confident, just understanding how I'm thinking about them, but then also the nuance as well. I really do need to evaluate them to be able to make a decision. If this person say they did not work, what is it about didn't work? Was it shoe fit? Was it the heel pressure, the arch pressure? Because all these things are changeable. And the reason we want to think that is it might be the slightest, easiest change, and that can have a huge impact where the heel does feel a whole lot better when they're in there, but it doesn't fit into the shoes that they wear to work, or they bought a new pair of shoes and it feels like it doesn't fit properly. We can help with those people, and we want to be able to help so we can work collaboratively. All right, 30 minutes I just spoke for flat out, and I reckon I could have gone on for 6 hours. I've kept it to 30 minutes. Hope that's good. Please, if you have any questions, I would love to talk about this stuff. I've got a talk coming out with Physio Network, which is going to be really exciting, where I'm speaking around these principles to, again, just have us all understand, because I feel confident in evaluating exercise, but from the communication and conversations that I've had, other people don't feel confident in evaluating foot orthoses. And I think it's something that we can work on to, again, achieve better outcomes, help podiatry become more recognized as well, and make something that we do that's pretty cool, more recognized. See you guys next week.